So hello, my name is Dr. Ukiri Richard. I continue our podcast today on basic cardiology, and today we are going to talk about shortness of breath with irritating cough. The case we are using today is that of a 68-year-old male patient that presented to you with three-week history of shortness of breath and irritating cough. There is no sputum, and when he lies on one side, he has chest pain. Apart from a pneumonia he had 5 years ago, there's no serious medical illness of note. In the body examination, 120 centimeters, 67 kilogram, blood pressure 140/80, pulse rate 77 per minute, regular. Heart sounds were okay. In the lung auscultation, the breathing was vesicular, only that you could hear a reduced breathing on the left, and on percussion there was dampening up to the scapular region. Still on the left. My question is, what test are you going to request for? Well, I request for laboratory tests, X-ray, ECG and ultrasound. In the laboratory test, I'll check for full blood count, CRP, electrolyte, creatinine, urea, CK, LDH, GOT, GPT, BNP and troponin. I'll do chest X-ray, ECG and electrocardiogram. You did your chest X-ray while the heart was normally sized. There were no infiltrations, no mediastinal widening, but you saw pleural effusion on the left. Just for a note, sometimes the pleural effusion can hide a space-occupied lesion or an infiltration. So, my question is name the diseases or disease conditions you know that can lead to pleural effusion. Well, there are one, oncotic hydrostatic conditions like heart failure, constrictive pericarditis, and hypoalbuminemia. 2, it could be infectious, either bacteria or virus. Pills, fungi or parasites. It could also be, don't forget, pneumonial, like for example pneumococcus pneumonia and pleura empyema. It could also be inflammatory and not infectious. The first one I talked about were inflammatory and infectious, but this could be inflammatory and non-infectious. It could also be paraneoplastic or neoplastic, for example, Pleura mesothelioma. It could be autoimmune or traumatic, for example, rib fracture, post-operative, and chylothorax. So now your blood test results are out, and CRP was significantly elevated, 90 milligram per liter. Normal is under 5. CK 388, LDH 284, GOT and GPT were normal. Total protein was 6.5 gram per DL. Troponin was negative. BNP was not elevated. You have the differential blood count was okay, but deep dimer was elevated, 2.94 milligram per DL. So you did the ECG. The reading was sinus rhythm, 70 per minute, with incomplete right bundle branch block. And in the echocardiography, you saw a normal heart size with normal regional pump function. There was no left ventricular hypertrophy. The valves were okay, no pericardial effusion. You saw the pleural effusion. So what is now your diagnostic plan? Well, when you have pleural effusion of unknown cause or of unknown etiology, it has to be punctured, and the punctate has to be sent for labochemical analysis, bacteriological analysis, as well as cytological analysis. So let me run down the inspection of pleural effusion. How to examine pleural effusion. Inspection, the normal effusion is supposed to be as the German called Bernsteinfarbig and clear. That has to be like diluted urine. If you have a bloody urine, think of a bloody effusion, you think of hematothorax, especially when the hematocrit is more than 50% of the blood hematocrit. You also think of a hemorrhagic effusion, like in tumor. It could also be artificial through puncture. If you have a concentrated effusion, you know that it has a lot of cells. Effusion that is milky or cloudy has a lot of fat. That is called chylothorax, where the triglyceride is more than 110 mg per dl, or it could be pseudo-chylothorax when the cholesterol is more than 200 mg per dl. If you have pus, then it is pleura empyema. Then, apart from inspection, let's move to the laboratory finding. If you have the ratio of the pleura effusion total protein to serum protein more than 0.5, that means if the total protein in the effusion is more than half that of serum protein, then according to light, it is an exudative effusion. Also, according to light, another criterion you can use to know if it's an exudative effusion is when the LDH in the effusion is more than 0.6 that in the serum, then it is an exudative effusion. Other laboratory indices are, if you have plasma glucose less than 60 mg per dl, you think of infections and collagenesis. If you have a pH between 7 to 7.2, you think of parapneumonia effusion. But if you have a pH less than 7, it is highly suggestive of a pleura empyema, which is an indication for surgical intervention. In the cytology, if you have neutrophilic abundance, it is suggestive of an acute inflammation. You have monocytic abundance, you even think of a chronic inflammatory process. If you have a lymphocytosis, think of tuberculosis and tumor. If you have eosinophilia, which is seldom, think of pleura asbestosis, Chaux-Strauss syndrome, Drexler syndrome, pneumothorax through medication or through medications. Also, don't forget to look for malignant cells in your cytological examination of the pleura effusion. In the microbiology, you check for normal bacterial, normal microbiology and mycobacterial studies. So let's come back to this your patient. You did a puncture in which 500 mils of pleura effusion was punctured that was red. The laboratory examination showed a red concentrated puncture with clear stand. The total protein was 4.4 gram per dl. Glucose was 103 mg per dl. Cholesterol 110 mg per dl. Triglyceride 30 mg per dl, and LDH 930 international units per liter. The microbiological tests were normal. There were no acid first bacilli like tuberculosis, and culture for mycobacteria was negative. In the cytology, there were no malignant cells. What is now your next diagnostic step? Well, I will do computed tomography of the thorax. Wall adherent tissue proliferation on the lateral thorax wall. There were no signs of pulmonary embolism in this patient with raised D-dimer, and you saw signs of low pulmonary emphysema. So you went ahead again to do a deepened occupational history, and you found out that the patient worked 20 years ago unprotected in an asbestos area, and already has and two of the co-workers from that period have already died from pleura mesothelioma. The next step now is actually to do a computer tomography guided puncture with biopsy, which you did, and he showed a poorly differentiated malignant tumor, although the tumor structure and the immune histochemical constellation actually support that of a mixed epithelioid sarcomatoid type, which is the biphasic variant of a malignant mesothelioma. What treatment option do you think we should consider in this our patient? Well, the truth of the matter is that we need a curative intervention in this patient with a very wide resection of the tumor. In this case, we must also do a pneumectomy, that is lung resection, and also partial resection of the chest wall. You thought of that, but the chest surgeon refused because of the age of the patient. What are you then going to do? Well, the next step is going to be a palliative treatment or care, which is actually a video assisted decortication with puncture canal radiation and chemotherapy, or alternatively you could do a fluoridase with talcum. Puncture canal radiation and chemotherapy can also be discussed. Thank you very much.